These are some of the Rhode Island statewide emergency medical services protocols, which may apply to respiratory distress, allergic reaction, and other protocols where you may utilize similar medications, such as obstetrical complications and crush injuries. So we're going to take a quick glance at three different processes: asthma, reactive airway disease, and COPD. In asthma, a person's airways become inflamed, narrowed, and swollen, and produce extra mucus, which makes it difficult to breathe. This is usually triggered by an allergen. Asthma is considered a reversible disease process, and again, it's caused by the narrowing of the bronchi and excretion of mucus secondary to immunoglobulin E, histamine. Reactive airway disease is a set of symptoms that may or may not be caused by asthma. So somebody may not be diagnosed with asthma, but they may have a diagnosis of reactive airway disease where they still get this short cough or wheezing or shortness of breath. Sometimes these terms are used interchangeably, but there are specific criteria utilized to diagnose asthma, reactive airway disease, and COPD. So that brings us to COPD, which is a chronic and non-reversible inflammatory lung disease that causes obstructed airway or airflow from the lungs. And one of the more common types is emphysema. This is the third leading cause of death in the United States, and it's a very costly disease process overall in the United States. Of course, symptoms will include difficulty breathing, cough, mucus or sputum production, and wheezing. The one thing that all three have in common is the wheezing is usually caused on the expiratory phase. So as a provider, when you listen to somebody's lung sounds, you have to make sure that you're listening to them breathe all the way in and continue listening to them breathe all the way out. Sometimes you'll have an inspiratory wheeze, and other times you will have expiratory wheezes. So you have to listen to the entire inhalation and the entire exhalation in each of the lung fields to make a good assessment and a good clinical differential diagnosis. Let's take a quick airway review. In most cases, air comes in through the nose of the nasopharynx, where it is warmed, filtered, and humidified. And this is done by nasoconchi and by the nares that are filled with hair. And those act as a filtration system. Air also comes in through the mouth or the oropharynx, meets in the back, which is the posterior pharynx, and it goes down the trachea via the larynx. So the larynx is where your voice box is, and you have your epiglottis back there to keep any food from going down into your lungs while you're breathing. And it opens to get the air to go through into your trachea, which is formed by C-shaped cartilaginous rings with the musculature in the posterior. Then you have your primary, secondary, and tertiary bronchi. Now, there are different names for this depending on what reference material you utilize. Some call these the main bronchi, lobar bronchi, and segmental bronchi. But one of the things that's important to you as a provider is that the musculature of the bronchi sits at the tertiary bronchi. So when you're bringing in albuterol or these inhaled medications, that's the portion that is becoming dilated. The terminal end is actually the alveoli, where the air enters the alveoli, and hopefully the air that you're bringing in is full of oxygen. There is vasculature that runs around the alveoli, and that vasculature drops off carbon dioxide and metabolic waste and hopefully will pick up oxygen and deliver that back to the heart, and you will expel air that's full of carbon dioxide and other waste. If you took all of the alveoli, which are little grape-like sacs, and you spread them out flat, they would fill the area consistent with that of a tennis court. So as you can see, there's a picture of a tennis court, and for anybody who understands Rhode Island history, that's actually the International Tennis Hall of Fame located on Bellevue Avenue in Newport. A very historic place. Going back to our lung fields, on the left you will see a part that says a normal lining. So the normal lining of the bronchi has a very small amount of mucus, and it is a nominal amount, which as we breathe in, we be breathing in dust particles and things like that. So every once in a while, you might have a coffee, you bring up something with a coffee, you spit it out, and that's the way we get that fluid full of dust and things out of our lungs. There's cilia that forms an area around the inside of these bronchi that allow us to push that uh, excrement out of our airway so we can cough it out. On the right side, you'll see a lung space or bronchi that has been swollen. There's excess mucus, and the lumen is significantly smaller. And that's what you would see in an asthmatic's lung. And these are the things that we're going to talk about as we move forward in this presentation with medication. So keep these in mind. So your body has enough blood to move around from place to place to affect a sympathetic or a parasympathetic response. So you have enough blood to be moved over to keep you from being eaten by a saber-toothed tiger, or go out on a hunt and hunt down a saber-toothed tiger so you and your family can have food to eat, or enough blood to shunt to your gastrointestinal tract and sexual organs so you can digest your food and make babies. Now, the photograph on the left of a saber-toothed tiger was designed and put there to startle you and create a fight or flight thought process in your head. The photograph on the right of the United States military parachute team coming out of the back of an airplane has nothing to do with digesting your food or making babies. I just wanted to declare that up front. However, the parachutes should remind you that the parasympathetic nervous system is all about things coming down, as you'll see. So the autonomic nervous system divided in sympathetic nervous system, with the main mediator of the sympathetic nervous system being norepinephrine, and that increases heart rate, increases respiratory rate, increases blood pressure, peripheral vasoconstriction, bronchodilation, and blood is generally shunted a little bit to the heart, lungs, and brain. Whereas your parasympathetic response, mediated by acetylcholine in the body, decrease in heart rate, decrease in respiratory rate, decrease in blood pressure. So everything's coming down, like as if you would put on a parachute and jump out of the back of a plane. There's peripheral vasodilation, there's bronchoconstriction, and the blood is generally shunted to the GI and GU tract and sexual organs. Homeostasis is maintained in the body through use of chemoreceptors or receptors. We are going to discuss three today: alpha, beta 1, and beta 2. An easy way to remember alpha is if you look at the alpha symbol, it kind of looks like the cross section of a vessel. And if you consider your blood vessels in your body with the same amount of blood going through them, if you were to take that blood vessel and make that diameter larger, where the interior has a larger diameter, that peripheral vascular resistance would be lower. So your blood pressure would be lower. If you were to take the same vessel and create a smaller lumen, which the internal diameter would be more narrow, the peripheral vascular resistance would be higher, so your blood pressure would go higher. Paramedics can control this with a drug called phenylephrine. But as you're going to see in the end, there's a medication that will also control this that can be given by providers at all levels. The next is beta 1. The difference between beta 1 and beta 2 can be simplified with a memory aid that is very simple. On a good day, most people have one heart and two lungs. Beta 1 affects the heart. It affects how fast the heart beats and how hard it beats. You may have encountered some patients who take beta blockers, like most drugs that end in OL, like metoprolol. Metoprolol can also be given by advanced life support providers on the ambulance for certain conditions. Beta 2 affects the lungs, and that affects the lumen size of the bronchioles. Now, can you think of a beta 2 drug that every provider can give? Well, generally, we don't ask each other to grab a medication out of the bag and say, will you please get me the beta adrenergic agonist, beta 2 selective? No, we say, can you please grab the albuterol 0.083%? We're going to put it in a nebulizer and administer it. Now, there is one drug that all providers at all levels are educated and trained to give that affects alpha, beta 1, and beta 2. And I want you to think of one condition that could cause us to use a medication that will affect all of these. If you've considered anaphylaxis, you're correct. There's an alpha response in anaphylaxis that makes the vasculature larger than it needs to be, and that makes the pressure go lower. Makes the pressure drop. You need to increase that also with beta 1 and beta 2 selective drugs because the bronchioles are now constricting, there's wheezing, there's stridor. So epinephrine affects all those receptors, alpha, beta 1, and beta 2, and that can be given by EMTs all the way up to paramedics. As we move forward in this presentation, a few terms are going to come up. So the first one is adrenergic. And adrenergic is considered a substance which stimulates nerves in the body by mimicking the action of the chemical messengers epinephrine and norepinephrine. If you think of the term epinephrine, epi means upon, the nephros have a lot to do with the kidneys. So when you think of upon the kidneys, what sits upon the kidneys? And that is the adrenal glands. This is your body's natural chemoreceptors or messaging chemicals that trigger the body to go into a sympathetic response. An agonist is a substance that acts like another substance, therefore stimulates an action. An antagonist, is a type of medication which blocks or dampens an action. So an opioid antagonist would be Narcan or naloxone. A cholinergic enhances the effects of acetylcholine, increasing the actions of the parasympathetic nervous system. So what's that going to do? Those are going to make things go down, right? Decrease heart rate, decrease respiratory rate, decrease blood pressure. So an anticholinergic drug blocks the effect of acetylcholine, reducing parasympathetic actions and increasing sympathetic ones. And the first drug that you should consider is ipratropium. It's an anticholinergic. And the other is atropine. Atropine speeds up the heart rate, not by triggering the sympathetic response, but by blunting or blocking the effects of acetylcholine or blocking the effect of a parasympathetic response. We're going to start by going over some of the inhaled medication, and you will see some examples of some devices that we utilize to administer inhaled medication, especially at the time this presentation was made during the period of COVID. We try not to use as many aerosolized medications as possible to avoid unnecessary exposure. One thing that I would like to point out, however, is the bullet that the medication is transported. If you look at the package, the packaging is pretty clear. It's usually color coded and there is writing in big white letters or black letters. But once those bullets are out of the package, it becomes very difficult to view what the actual medication is. It's embossed in the side of the plastic. So always be very careful to confirm the medication that you're giving. Albuterol is a short-acting beta-2 selective adrenergic receptor agonist. It's used in the management of bronchospasm because it ultimately relaxes bronchial smooth muscle. It also has other uses such as premature labor and hyperkalemia. When we think of the term beta adrenergic agonist. An adrenergic means working on adrenaline, which is epinephrine, or non-adrenaline, norepinephrine, or their receptors. It usually is used in the sense of enhancing or mimicking the effects of epinephrine and norepinephrine in the body. And the term agonist means a substance that acts like another substance and therefore stimulates inaction. It is important for providers to understand that even though a specific medication may be, like in this case, a beta adrenergic agonist, beta 2 selective, that medication still has other properties. So it still has beta 1 properties. So you may see some side effects going along with the administration of this medication, such as tachycardia, palpitations, or cardiac ectopy on the cardiac monitor. Some people may get a tremor or a headache or nausea or vomiting. Now remember, I talked about earlier the shunting of small amounts of blood from the gastrointestinal tract and sexual organs to the heart and the lungs and the brain. So once somebody feels that they cannot breathe, where do you suppose all their blood wants to go? It's protective. That majority of their blood wants to go to their heart, their lungs, and their brain to keep them alive. So guess what gets abandoned? The GI tract. So all that blood, or a large majority of that blood, is pulled from the GI tract to assist the other areas of the body that are your primal areas where you want to stay alive. So those people might get increased nausea and vomiting and gastric upset with this. Of course, tachycardia is a relative contraindication to the administration of albuterol sulfate. And the reason is it may make them tachycardic. Now, if somebody's mildly tachycardic because they can't breathe, that's understandable that you need to fix the problem, especially if they're experiencing an asthma attack. But if you come upon somebody who has a heart rate in the 170s, 180s, or they're in SVT or they're in VTAC, that's not a good idea to administer albuterol. These are case by case dependent situations, so always refer to your standing orders, your protocol, and consult medical direction if you have any questions. Ipratropium bromide is not only fun to say, but it is an anticholinergic. An anticholinergic drug blocks the effect of acetylcholine, reducing parasympathetic actions and increases sympathetic ones. Wow, it's a lot of big words there. But let's talk about the process of an asthma attack. You have bronchoconstriction. When you are faced with an allergen, what does your bronchi want to do? Open up and let more in? No, of course not. It wants to constrict and keep as much of that allergen out as it can. There's inflammation there, and there's inflammation mediated by a histamine response through IgE or immunoglobulin E. And there's a mucus that always sits in the lung fields, but it's a minute amount until something like this happens. So, generally speaking, ipratropium is given to dry them out, whereas albuterol is given to these asthma patients to increase the lumen size of the diameter of the bronchioles. Anticholinergics are also given in other situations. If you can think of another anticholinergic that you carry on your ALS ambulance, atropine. Atropine speeds up the heart rate, not like epinephrine does, not by a sympathetic response. It speeds it up because it blocks or blunts the parasympathetic response. Atropine, also an anticholinergic. Paramedics will be able to give atropine in the case of increased salivation when you give ketamine. So there's a thought process that you should come to that makes you realize that ipratropium anticholinergic dries them out. Levoalbuterol is classified as a beta adrenergic agonist, beta 2 selective. Remember, adrenergic means working on adrenaline, epinephrine, or noradrenaline, norepinephrine, or on their receptors. It is usually based in the sense of enhancing or mimicking the effects of epinephrine and norepinephrine in the body. Agonist simply means a substance that acts like another substance and therefore stimulates an action. Both albuterol and non-albuterol contain isomers. Albuterol is a 50-50 racemic mixture of two isomers, the R isomer, which causes bronchodilation, and the S isomer, which is devoid of any clinical utility, but believed to increase airway reactivity and may contribute to paradoxal bronchospasms. Levalbuterol does not contain the S isomer. It only contains the R isomer. So it is a paramedic level medication that's used for bronchospasm associated with asthma or COPD. Epinephrine 2.25% solution, also known as racemic epinephrine, is an alpha and beta agonist. You remember, an agonist is a substance that acts like another substance and therefore stimulates an action. In this case, it stimulates alpha, beta 1, and beta 2 antinergic receptors, resulting in relaxation of smooth muscle of the bronchial tree, cardiac stimulation, which increases myocardial oxygen consumption and demand, and dilation of skeletal muscle vasculature. Small doses can cause vasodilation via beta 2 vascular receptors, and large doses may produce constriction of skeletal and vascular smooth muscle. So when do we give this? We give this during that call in the middle of the night where a child is having difficulty breathing. Maybe that child has had a cough or a runny nose for a day or two. Maybe they've had a fever. But the hallmark sign is the seal-like barking cough. That wins the undivided attention of parents, and when the call goes out for a pediatric patient in respiratory distress, it has also won the undivided attention of every EMS provider on the way to that call. They call it laryngotracheobronchitis, croup for short. It's swelling of mostly the upper airway. In Rhode Island, EMT cardiacs and paramedics can administer racemic epinephrine by protocol, or they can administer a nebulizer with 5 milligrams of 1-to-1 epinephrine. Pictured is epinephrine 1 milligram in 1 ml. This used to be called 1-to-1 or 1-to-1000. You'll be utilizing a 1 milliliter syringe to draw up the dose for either an adult or a pediatric patient, as the adult dose maxes at 0.3 milligrams, which is also 0.3 milliliters of the 1 milligram to 1 ml solution. The use of an autoinjector is strongly recommended for administration of IM epinephrine at all provider levels if available. Epinephrine is classified as an endogenous catecholamine. Endogenous simply means that it occurs within the body, and catecholamines are hormones that the brain, nerve tissue, and adrenal glands produce. The release of catecholamines is in response to physical or emotional stress, also known as the fight or flight or sympathetic response. Epinephrine is the synthetic formulation of the endogenous hormone or naturally occurring hormone, adrenaline. It is a potent stimulator of both alpha and beta receptors. And as we talked about earlier, alpha 1 results in vasoconstriction and increased afloat. So somebody experiencing an anaphylactic reaction, that's what you want. You want vasoconstriction because their blood pressure is probably very low. Beta 1 receptors result in increased contractility, heart rate, and conduction velocity. Again, somebody who's experiencing a true anaphylactic reaction will have a blood pressure that is low, leading to a low mean arterial pressure, leading to poor cellular respiration. Beta 2 effects, although they include vascular smooth muscle relaxation or vasodilation, that's countered by the alpha effects. But the beta 2 effect that you're looking for, the administration of epinephrine in anaphylaxis, is bronchodilation. Earlier, we talked about other signs and symptoms of anaphylaxis, and one of them is stridor. Stridor is an upper airway noise that's caused by constriction of the upper airway. Once the upper airway begins to swell, you can imagine what the lower airways sound like. So any stridor, difficulty breathing, epinephrine should be on the forefront of your mind for rapid administration. In this presentation, you have heard us kick the term around homeostasis. It means the body striking a balance. When you are about to give a medication or considering administering a medication to a patient with shortness of breath or certain symptoms, there is another effect that could occur, especially with a medication like epinephrine, where you are increasing the heart rate and therefore increasing myocardial oxygen demand. That simply means the heart has to work harder. It's going to need more oxygen to help it out to get that done. Ironically, you're considering administering the medication because there is a systemic or respiratory issue causing them to be hypoxic. So, allergic reaction or anaphylaxis in patients greater than or equal to 50 years with a history of cardiac disease or a heart rate greater than 150 are at risk for cardiac ischemia following the administration of epinephrine. These patients should have ongoing cardiac monitoring and a multi-lead EKG following the administration of epinephrine. Asthma and allergic reactions of mild or moderate severity and no respiratory symptoms to include wheezing, dyspnea, or hypoxia, epinephrine administration should be avoided in patients greater than or equal to 50 years of age due to the risk of adverse cardiovascular events. Epinephrine should never be withheld in cases of allergic reaction or anaphylaxis with severe symptoms. Paramedics have the ability to administer magnesium sulfate 2 grams to adult patients in respiratory distress. Magnesium is a non-selective calcium antagonist and blocks a number of calcium-dependent processes. By inhibiting calcium uptake by smooth muscle, administration results in bronchial, vascular, and uterine contractions. This makes it useful in the management of bronchospasm, and it may also be administered by paramedics for women in premature labor. At that point, it's administered at a different dose. Earlier, we spoke about the inflammation involved, especially with asthma. Solu Medrol, or methylprednisolone, is classified as a synthetic glucocorticoid or a synthetic steroid. They are found almost everywhere in the body, in every cell, and exert a powerful effect on the body. Because methylprednisolone inhibits the inflammatory and immunologic response, it is useful in the management of allergic and anaphylactic reactions and in the management of disease processes that involve airway inflammation or edema, reactive airway disease, or asthma, for examples. Reduction of inflammatory mucosal edema, bronchial smooth muscle reaction, bronchial vasoconstriction, and decreasing capillary permeability, and they may restore the responsiveness of an asthmatic patient to beta agonists. Dexamethasone is another steroid or glucocorticoid that paramedics are able to administer. It has the same or similar profile as methylprednisolone. Prednisone is a corticosteroid. Paramedics have an option of administering prednisone or dexamethasone under Protocol 2.08 respiratory distress. Another corticosteroid that paramedics may administer is prednisolone sodium phosphate, which is a relative of prednisone, which is like a corticosteroid. It acts in the same manner. I have saved this slide for last because now you have reviewed all of the information provided about medications, and you come to this last slide armed with a little bit more knowledge than you had before you started, hopefully. I'm often asked by providers, how do I tell the difference between asthma, COPD, acute decompensated heart failure, pneumonia, or even COVID-19? They get concerned that they won't be able to distinguish between these disease processes when assessing a patient in the field. The best advice I can give is to perform a methodical and thorough assessment. Start with subjective information given to you by the family or the patient. Include a thorough past medical history, including heart problems and lung problems. Include any medications that the patient may take. A patient who may take a lot of inhalers may point you more to the direction of COPD or asthma, whereas a patient who takes diuretics such as furosemide or spironolactone may point you to processes where the patient needs to get rid of extra fluid from time to time because of underlying medical conditions with their heart. Know any allergies. People with sensitivity to aspirin may start on an aspirin regimen and not realize that this COX-2 inhibitor is causing this short cough and these respiratory airway distress syndromes, such as wheezing or coughing. Or surgery. Recent surgeries where people sit still for long periods of time thereafter, they may be developing a pulmonary embolism. You always have to be mindful of an anaphylactic reaction, which you should be able to recognize from across the room in most cases. Does a patient smoke cigarettes? Does a patient drink a lot of alcoholic beverages? Does a patient ingest drugs? Any recent travel history? Is anybody close to the patient sick? This may point you to cases where contagious disease processes, such as COVID-19, may be the root cause of this patient's issue. Supply any objective information, and what's most important is a solid head-to-toe assessment. You're going to include what you see. Does the patient have distal pedal edema? That's pitting or not pitting. How are the patient's lung sounds when you listen during inspiration and expiration? Is there stridor? Is there wheezing that's audible without a stethoscope? Are there rales? Included in the assessment are your findings as far as a full set of vital signs, including a respiratory rate, end-tidal CO2, SpO2 monitoring, obtaining an EKG and a 12-lead EKG, and a posterior or right-sided EKG if you need to. Temperature is very important as well. Is this person running a fever, which may point you to COVID-19 or pneumonia or other disease processes? You have to put in the work. You need to know and understand the pathophysiology of certain disease processes. What signs and symptoms would you expect to witness with each? Generally speaking, asthma is a condition of childhood. It's usually diagnosed in a patient's younger years, their adolescence or young adult moments like 20s or in their teens. However, young patients become old patients, and now you have the disease processes that are usually diagnosed in the older years, such as COPD or emphysema. Acute decompensated heart failure, by virtue of the name acute decompensated heart failure, is actually a respiratory disease caused by a cardiac problem. You have an inefficient pump. There's a problem. There may be a non-STEMI or a STEMI. There may be tachydysrhythmias or bradycardias involved. So you have to be alert and listen to your patient's backstory. Do they take these loop diuretics or these diuretics, or do they take a pile of inhalers? So that might clue you in. Make this more convoluted, it is quite possible that somebody was diagnosed with asthma when they were 9 years old. They were diagnosed with COPD and emphysema when they were 65 years old, and they have exacerbation of acute compensated heart failure, all having a pneumonia, and now they have a COVID-19 diagnosis as well. So is it possible to have all of these? Yes, it is. So you are at a disadvantage from the emergency department, where the emergency department has laboratory testing and imagery available to them in the form of X-ray or even CT. So don't be afraid to consult your online Rhode Island statewide emergency medical services protocols. And if you're still confused or you have questions, consult with a physician. Your medical online direction will assist you in making these difficult decisions in the field. This presentation was made utilizing the Rhode Island EMS Protocols version 2020.02 and the Rhode Island Department of Health Center for EMS 2017 EMS Pharmacology Guide version 2017.0, written by John N. Plikus. Special thanks to Chief Plikus for writing this publication. I recommend that all providers enter this publication, read it, and come to know the medication that you have at your disposal that you can administer to patients.